All right, today we're going to take a deep dive into Momelotinib. This is a really fascinating new agent in hematology oncology, and it's making some serious waves. We're going to walk through all the key clinical evidence and, most importantly, see how it's actually being used for our myelofibrosis patients with anemia.
So let's just cut right to the chase. What's the big headline? Momelotinib is, right now, the first and only approved treatment that specifically goes after the problem of anemia in myelofibrosis. And, this is key, it's for patients whether they've had a prior JAK inhibitor or not. That's a huge deal. So here's our game plan. We'll start with why this is such a novel therapeutic option. Then we'll get into the real meat of it, the pivotal data from 3 major trials. From there, we'll talk practical stuff like patient selection and dosing, and then connect it all to what really matters, clinical value and survival. And we'll wrap it up with a quick prescribing summary. Okay, first things first. Let's talk about the clinical challenge. As you all know, anemia in myelofibrosis is a massive, persistent problem. It's exactly this critical unmet need that momelotinib was developed to address. So what is momelotinib really? Well, it's not just another JAK inhibitor to add to the list. It's a first-in-class therapy, and its approval really carves out this very specific, very important niche in our treatment algorithm for that tough-to-treat combination of myelofibrosis and anemia. Now for the part we've all been waiting for. The evidence. The case for momelotinib isn't built on flimsy data. It's standing on a really powerful foundation of 3 large-scale phase 3 trials. This table gives us a fantastic bird's-eye view of how thoroughly this drug was tested. You can see they looked at it from every angle. The Momentum trial looked at the second-line setting. Simplify-1 took on the first-line, treatment-naive patients, and Simplify-2 tackled that really difficult group who had already failed other therapies. Each study answered a really distinct and important clinical question. Okay, let's zoom in on the Momentum trial. This was for patients who'd already been on a JAK inhibitor. And the results? They were absolutely definitive. Momelotinib was superior to the active comparator, danazol, across every single key endpoint: symptom scores, spleen reduction, and, of course, the big one, transfusion independence. This really positions it as a new standard of care here. Now for the first-line setting in Simplify-1. This is fascinating. While it was non-inferior to ruxolitinib for spleen reduction, look at the anemia benefit. That's the real story. We're talking a transfusion independence rate of over 66% for momelotinib compared to just under 50% for ruxolitinib. That's a clinically meaningful difference. And finally, what about that incredibly difficult-to-treat group? The patients who have already failed other JAK inhibitors. The Simplify-2 trial confirmed momelotinib's unique benefit here too. It literally doubled the rate of transfusion independence compared to the best available therapy, 43%. That's a game changer for these patients. So, with such compelling evidence, the next question is pretty obvious, right? How do we take all this data and actually use it in our day-to-day practice? Who do we give it to, and how? Well, the data gives us a really clear picture of the ideal patient. We're talking about our myelofibrosis patients with anemia, especially those with a hemoglobin under 10 or who are needing transfusions. It's also a fantastic option for patients who also have thrombocytopenia, a group where, our options have been pretty slim. And the dosing, you're gonna love this. It is refreshingly straightforward. Just a single 200 milligram pill once a day. That kind of simplicity is a massive advantage when we're managing these already complex cases. Now, this simple dosing leads to a really crucial practical advantage. You know how with other JAK inhibitors we're often forced to dose reduce because of cytopenias? Well, momelotinib has a low myelosuppressive effect. This means we can actually maintain the full effective dose, which is absolutely critical for getting the best possible results. So we've got strong efficacy, we've got a practical dosing schedule, but now let's connect all of that to the thing that matters most, improving patient outcomes and ultimately survival. And this right here is probably the most important takeaway of this entire discussion. Improving anemia isn't just about quality of life. The clinical data show a direct, undeniable link. Patients who become transfusion independent on momelotinib live significantly longer. This proves that treating the anemia isn't just supportive care, it's a truly disease-modifying intervention. And the value proposition just keeps going. Long-term data confirms a favorable safety profile, no new scary signals. And think about it from a healthcare system perspective. When you reduce the incredible burden of blood transfusions, you're talking lower costs, fewer clinic visits, and a much, much better quality of life for your patients.
Okay, let's pull all of this together. Let's create a clear, actionable summary that you can take right back to your clinic.
When you get right down to it, it's about 3 core principles. Step 1, identify the right patient, the one with myelofibrosis who is struggling with anemia. Step 2, prescribe the simple 200 milligram once-a-day regimen. And step 3, expect real, tangible benefits, especially a reduced need for transfusions and, critically, the potential for longer overall survival.
So I'll just leave you with this question to think about. Based on all this evidence we've just walked through, how is this new agent going to change the way you manage these challenging cases of myelofibrosis with anemia in your own practice?